Good afternoon. I'm Dr. G.N. Ramesh. I'm a consultant in gastroenterology at Aster Medcity, Cochin, Kerala. And with me here today is Professor Horst Neuhaus, who's a celebrated gastroenterologist whom we all know. Welcome to you, Professor. The small bowel has always been a challenge for the endoscopist because it's presented with itself a lot of problems, challenges in imaging. And I understand that you have been one of the pioneers of endoscopic imaging of the small bowel. Could you just walk us through the challenges that you faced in the development of imaging of the small bowel?
Of course, there are a couple of important indications for small bowel examinations by means of endoscopy, obscure GI bleeding, early stages of Crohn's disease, but also therapeutic interventions for treatment of strictures. And in the year 2000, as you well know, the capsule endoscopy was invented, and this changed the scenery, so it's now very easy and still the first step to do capsule endoscopy for complete imaging of the small bowel. But as endoscopists, we would like also to do interventions, to take biopsies or to remove polyps, as we do in the upper and the lower GI tract. And the problem is, of course, the length of the small bowel, 5 to 6 meters, and to overcome all the different loops. And in 2002, balloon-assisted enteroscopy was introduced, which is excellent, but it's not so easy for beginners to learn it, so it's a longer learning curve, and it's quite time-consuming. And as an alternative, spiral enteroscopy was introduced, and more than 20,000 procedures were done worldwide with the overtube. And in principle, a spiral is integrated in the tube, and with this spiral, the tube is driven, and the spiral pleats the bowel onto the tube. But it has not gained wide acceptance, as I know, in Asia, neither in Europe, but more in the United States, because a second endoscopist has to drive the spiral, which is also time-consuming. And therefore, Olympus acquired the company and developed the first motorized endoscopy. This is the first active endoscope.
So one of the biggest advantages of a spiral enteroscope, which we've been given to understand, is that it makes the examination time shorter, and you can examine a larger length of the bowel at a shorter time. Is it true, or has it been borne out by evidence?
Not in this respect that there is not yet a randomized controlled trial. So we did the very first spiral enteroscopy with a motorized system in 2015, so it took a long time, and I think it's a masterwork of engineering to develop the first active endoscope with an integrated motor, and the motor drives a coupler at the distal part of the endoscope, and this is connected with a disposable spiral of 24 centimeter length, and then the spiral can be rotated clockwise and counterclockwise with a foot switch, and also it measures the force gauge to avoid the risk of entrapping small bowel. And it's obviously quite fast. So in the first two-center prospective trial, we enrolled 132 patients. And on average, it takes about 25 minutes to reach the deepest point.
Okay.
And in the first trial, we reached the cecum in 11% of the cases. So obviously, the penetration is quite deep and it's quite fast, but we don't have the direct comparison.
So that's quite a big advantage. But do you think that does it come with all these advantages a baggage of risks also, as compared to the conventional enteroscopes, the double balloon or the single balloon?
Again, we don't have a direct comparison. We had in this first trial, we had 2 serious adverse events, one small perforation in the terminal ileum, and it remains unclear if this has been related to APC, what was done during the procedure, or was it caused by the spiral itself. And the second complication was the bleeding at the EG junction, probably induced by passing the spiral. So this compares also to other enteroscopy techniques which have a potential risk of perforation.
The characteristics of the tube, the scope, the insertion tube, is it bigger than or wider than the conventional enteroscope, the single balloon or double balloon?
The endoscope itself is comparable to a pediatric colonoscope. It's 164 centimeters long, and this is the advantage. It has a 3.2 millimeter working channel, so we can use any accessories as we do for colonoscopy for interventions. But the spiral, of course, has a larger diameter, but the fins are very soft, but there is some resistance passing the upper esophageal sphincter, so we routinely do bouginage before the intervention with this 18 millimeter bougie. And the second challenge is to overcome the area of ligament of Treitz.
Yeah. I guessed as much. The DJ flexure may pose a challenge because sometimes it's very acute. So how is it that you negotiate tips for the learners? What are the tips that you would give to people who want to learn this art of spiral enteroscopy?
Yes, the learning curve is relatively short, but in any way, any case, I think this is also has to be appreciated that Olympus company takes it very seriously. So all those who want to acquire the technology have to pass a course, and we offer them in our institution. And this includes theoretical introduction and then also doing procedures in a model, and then to observe live procedures. It's a 2 days course. The learning curve is relatively short, so I would say after 20 examinations you feel quite comfortable.
And would a retrograde examination also be all that easy, or is it more difficult?
No, it's not more difficult. We did another trial which was presented at the DDW this year, and we enrolled 30 cases with the aim to achieve a complete enteroscopy. So we selected only patients with indications to see the whole small bowel, and we reached from the peroral side the cecum in 17% of the cases, and with combination with the retrograde. So if it didn't reach, we marked with tattooing the deepest point of insertion, and then on the next day we did the retrograde enteroscopy and achieved another 53% the complete enteroscopy. So 70% is the overall rate, and once the spiral is inside the terminal ileum, then it's usually going quite fast from below.
But getting into the terminal ileum is a challenge.
Yes.
So the DJ flexure is a challenge, the ileocecal valve is a challenge. So these are the two areas where it could be a problem. Okay, but where do you see over the next decade or so spiral enteroscopy going? Now, do you see enteroscopy climbing up the ladder of the algorithm as far as small bowel evaluation is concerned, or
I think
after capsule or before capsule?
No, I would say after capsule. It's still an invasive procedure. Maybe except patients with severe bleeding, where immediate intervention is required, but otherwise capsule is the first step. Also to guide us, for example, if we see patients with capsule endoscopy with angiodysplasias located only the upper small bowel, only in the jejunum, then we know we have not to penetrate deeply into the ileum, so this is helpful. So capsule is the first step, but in terms of the comparison between balloon enteroscopy and spiral enteroscopy, I would say spiral enteroscopy is fast, shorter learning curve, easier to do interventions because we have a very stable position with this instrument, and the 3.2 2 millimeter working channel. We don't know yet how it works in patients with an altered GI anatomy. We did now about 13 cases with ERCP. This was initially an exclusion criterion, but now we do also spiral enteroscopy with a motorized system in patients with altered GI anatomy. It works well. But in cases, for example, a lot of adhesions or so, it may be more difficult. So I think it will not replace balloon enteroscopy, but my message is patients with indications for small bowel enteroscopy should be centralized. And these centers should have all the various technologies to provide the best care for our patients.
Thank you very much, Professor. Yeah. You are in conversation with Professor Horst Neuhaus, a celebrated gastroenterologist who's worked so much in small bowel endoscopy, and thank you very much.